Hello guys, with you Dr. Muhammad Hamid, an ECFMG certified physician, and today we are going to go through some of the high yield stuff for cardiovascular system for the USMLE Step 1 exam. So our first topic here is high output heart failure. So this is an uncommon condition. So this is an uncommon form of heart failure, not like the systolic and the systolic one. There is here also there is heart failure, there is increase in the cardiac output. So this occurs in kind of different causes. These causes have a common factor inside of them, either vasodilatation or arteriovenous shunting. So you have to have arteriovenous shunting or vasodilatation, and counterbalance mechanism, there is increase in cardiac output to maintain the circulation. So as you know that for the blood to circulate in your body, it has depends on the cardiac output and the systemic vascular resistance. So if there is vasodilatation or EV shunting, you have to increase the cardiac output for. So to break that down, the causes include severe obesity, hypermetabolism, and advanced cirrhosis. It includes splanchnic vasodilatation and severe anemia and hyperthyroidism. Severe anemia, there is low hemoglobin, so the blood has to go through the circulation more times, so you have high output heart failure. So for the hyperthyroidism also, there is hypermetabolism and increased catecholamine levels, and also this may lead to high output heart failure. With beriberi, you know that with beriberi, due to thiamine deficiency, it also involves vasodilation and Baggett's disease of the bone. It is hypermetabolism of the bone and increase bone turnover. So also there is arteriovenous shunting inside the bone. So these different kind of causes may cause vasodilatation or arteriovenous shunting, and the cardiac output will increase, and you may reach a point for the heart to fail. This is a high output heart failure, and the patient in this case present with signs of pulmonary or systemic venous congestion. So they will have both systemic venous congestion means the right side heart failure, and pulmonary means the left side heart failure. So you have the kind of both the symptoms of right and left heart failure. You will have pulmonary congestion and systemic venous congestion in high output heart failure. Again, this is a very important topic here is shock. So for the shocks, they are subdivided into different kind of shocks. There's hypovolemic shock, cardiogenic, obstructive, and distributive shock. So we have our table here, very high yield. We're gonna spend some time in it to break it down further. So we will start by the SVO2. So the SVO2 is the saturation of the venous oxygen, and the SVR, the systemic vascular resistance, cardiac output. This is BCWB, which is pulmonary capillary wedge pressure. The pulmonary capillary wedge pressure means that you will insert a Swan-Ganz catheter inside the circulation, and it will travel to left side of the heart, and then will go to the right side of the heart, and we go through the pulmonary artery till reaching the faster small arterioles, and it will be lodged. So it will transmit the back pressure from the here the right atrium, left atrium. So the left atrium pressure will be transmitted, and so this catheter will measure the left atrial pressure. So pulmonary capillary wedge pressure is equivalent to left atrial pressure. So whenever you hear pulmonary capillary wedge pressure, it is equivalent to left atrial pressure. So this is the CVP, central venous pressure. So first, we will compare the different kind of shock according to the saturation of the venous oxygen. So this through a central venous catheter inserted into the internal jugular veins, you may withdraw a sample of blood. So from this sample you will measure the oxygen, and logically it will be decreased. You have shock, and the tissues are not well perfused, so it will extract as much oxygen as possible, and the saturation of the venous oxygen will be is gonna be low, except in distributive shock in sepsis. This is due to mitochondrial toxicity in the sepsis or anaphylaxis. There may be a mitochondrial toxicity, so the tissues are not gonna extract oxygen well, so you will have increased in the saturation of venous oxygen from the central line. So this is a very high yield point to if you have a patient who has shock and you don't know whether it is septic shock or cardiogenic shock, you gonna withdraw a sample from the central venous catheter and just examine it for the saturation of the venous oxygen. It will be increased in the distributive shock and the septic shock, and it will be decreased in the cardiogenic shock. So for the systemic vascular resistant, you don't have to memorize anything, just understand the mechanism. So the hypovolemic shock, there is no volume inside of your body, so and the vessels are gonna constrict, so the systemic vascular resistance is increased. Also for the cardiogenic shock, decrease the cardiac output here, and also the vessels are gonna constrict, obstructive shock also. So all of this will have increased systemic vascular resistance except the distributive shock. So you know the neurogenic shock involves vasodilation, and septic shock and anaphylaxis, all of them involve vasodilation. So this is the different ones here. The distributive shock involves decrease in the systemic vascular resistance. So for the cardiac output, of course, the cardiogenic shock is the defect here is in the heart. So cardiac output will be decreased, and the obstructive shock, pulmonary embolism, and different kind of things that will obstruct the heart. Cardiac tamponade means pressure on the heart. Pulmonary tension, pneumothorax also gonna constrict the great vessels in the thorax, and so this will decrease the cardiac output. But for the distributive shock, the primary defect here, you remember, here is the peripheral vasodilation. So uh, the heart is gonna counteract in the sepsis and anaphylaxis by increasing its cardiac output. But for the CNS injury, you may involve the CNS and its effect on the heart. So it will have both decrease in the cardiac output and decrease in the systemic vascular resistance. So this is for the cardiac output. The pulmonary capillary wedge pressure, you remember the definition of it. It measures the left atrial pressure. So yeah, whenever you have hypovolemic shock, there is no fluid in all the body or in the circulation. So the pulmonary capillary wedge pressure is logically to be down. It's very logical. And for the cardiogenic shock, the heart is not able to push forward the blood inside of it, so it is gonna go backward. So when it goes backward, it will go back to pulmonary vein to the catheter. You remember the catheter that is inserted in the terminal arteries of the pulmonary artery. So the left atrium pressure is increased, and the pulmonary capillary wedge pressure is equivalent to left atrial pressure. So the pulmonary capillary wedge pressure will be increased in cardiogenic shock. And for the cardiac tamponade versus pulmonary embolism, different kind of mechanism. For the cardiac tamponade, the heart is contained and surrounded by fluid. So the heart is surrounded by fluid all over it. So it's constricting the heart and is not giving him the space to pump blood. So the pressure will build up and will build up in the left atrium and transmit back, and so the pulmonary capillary pressure will be increased. Unlike the pulmonary embolism or tension pneumothorax, you remember that the pulmonary capillary pressure again equals the left atrial pressure. So if a pulmonary embolism obstructs the pulmonary artery, no sufficient blood will flow to the left atrium, and the tension pneumothorax, which may compress the artery also and disturbs the circulation. So you will have decreased pulmonary capillary wedge pressure. So for the distributive shock, also as the hypovolemic shock, we will have a decrease in the pulmonary capillary wedge pressure due to vasodilation. So the CVB just follows the pulmonary capillary wedge pressure, so it is the same. So the decreased pulmonary capillary wedge pressure means decrease in the CVB, and the increase if the pulmonary capillary wedge pressure means increase in the CVB. So it is just the same, except here in the pulmonary embolism it is due to that the pulmonary embolism will obstruct the pulmonary artery, but it will cause back pressure to the right side of the heart and to the superior vena cava, and the CVP or the central venous pressure in the internal jugular vein is increased, but the left atrium is not. There will no much pressure increase, so that is the difference, but otherwise it is just the same. And for cardiac tamponade, this is a picture here showing the cardiac tamponade. So it means just compression of the heart by fluid, not needed to be blood, maybe by effusion. So this leads to decrease in the cardiac output and equilibration of the diastolic pressure in all the four chambers, no space for the heart to pump efficiently. And the finding is called something very high yield called the big triad. So for the big triad, when you encounter a patient who has hypotension and the distended neck vein, the third thing you gonna do is to put a stethoscope on the patient's chest. So if you uh, auscultate a distant heart sound, this completes the big triad. So you will find a hypotensive patient, the patient may have distended neck veins and the distant heart sound. This is the big triad, which is characteristic for cardiac tamponade. And as a result of cardiac tamponade, the heart rate is gonna increase as a counter balance mechanism, and it will have something peculiar called the pulsus paradoxus. So pulsus paradoxus means just the decrease in amplitude of the systolic blood pressure for more than 10 millimeter Hg during inspiration. So during inspiration, that you remember that in the heart during inspiration the blood will go and here through the right ventricle will go more, and it will just push the interventricular septum to the left side of the heart. So with inspiration means increase in the RV filling, and the will push the interventricular septum towards the left ventricle. So there is a pressure from inside the heart, and you remember there is also pressure in cardiac tamponade from outside the heart. So the left ventricle is not taking its ease at pushing blood. So this will further decrease the systolic blood pressure by more than 10 millimeter Hg, no good pumping of the heart, and so decrease in the left ventricular ejection volume and the decrease in the systolic blood pressure. It is not just seen in constrictive pericarditis, so it is also seen so in cardiac tamponade and in constrictive pericarditis, and in the kind of different kind of pulmonary conditions is mostly asthma and COPD. Very high yield to know that some chest condition also may cause pulsus paradoxus. So croup and obstructive sleep apnea, and they are less frequent than asthma and COPD. They are kind of upper airway problems, unlike asthma and COPD. So let's complete the ECG may show low voltage QRS as a heart is not taking its ease at pumping blood. So of course the voltage are gonna be low, so the QRS will be lower than usual, and electrical alternance. So this is electrical alternance. This is there is not the same in the height of there is no the height of the different kind of QRS complex is not the same. So this is electrical alternate. The heart is just swinging in the fluid, and so this is electrical alternate. So swinging movement of the heart in the large effusion. So the echocardiogram of course will show the pericardial effusion. Here this is a pericardial effusion surrounding the heart and systolic right atrial collapse and diastolic RV collapse. So with this all the fluid or blood surrounding the heart, there will be systolic RA collapse and diastolic RV collapse, and IV plethora, the IVC is gonna be distended and plethoric. So the treatment, you have to do either pericardiocentesis or a surgical drainage, and you have to do some kind of consultation to decide that. Our next topic is syncope. So not much high yield. So you have reflex syncope orthostatic syncope, and the cardiac syncope. So first you have to exclude the most dangerous one, which is cardiac syncope, maybe due to arrhythmia or structural heart disease. So the patient may go into syncope, and the cause may be arrhythmia. The patient may have transient AF or transient supratachycardia, and this called paroxysmal AF or paroxysmal supraventricular tachycardia, and the heart rhythm, the patient restores a normal heart rhythm on its own. So this may, you have to exclude that. You may do Holter for the patient. And for structural causes, very famous causes for syncopes are aortic stenosis, of course, for this in older people, and hypertrophic cardiomyopathy in younger people. This is a kind of maybe genetic or something. We have explained that different kind of causes of hypertrophic cardiomyopathy. This is the most dangerous, and the most benign is the reflex, maybe vasovagal. This is the most common syncope you're gonna witness, is the vasovagal attack due to emotional, the patient being emotional or something, and it is called the common faint. And the situational, some people during ordinary process of the body, such as coughing, sneezing, swallowing, defecation, micturition, all of that, this kind of population may have a situational syncope. And in the vignette, you may find something called the carotid sinus hypersensitivity. The carotid sinus in your neck may be very sensitive or hypersensitive. The patient may complain of a syncope while wearing a tight collar or something, or the patient touches his neck and then fainted in the vignette. So this is called the carotid sinus hypersensitivity. And the orthostatic syncope due to hypovolemia or drugs such as antihypertensive toxicity, or the patient took so much dose of antihypertensive and gets drugs and gets syncope. And autonomic dysfunction, of course, the diabetes mellitus may cause autonomic dysfunction or neuropathy and cause syncope. So there is a term called orthostatic hypotension. That means that when you measure the blood pressure of the patient lying and standing, you will notice a difference for the systolic blood pressure more than 20, and for the diastolic blood pressure more than 10. If this occurs, this means that this patient has orthostatic hypotension. So this is for the syncope. And next very important topic is infective endocarditis. So infective endocarditis, from the name, it has infection, and endocarditis, the affected layer is the endocardium carditis, the inflammation of the endocardium due to an infective cause. So this infection of the endocardial surface of the heart typically involves more or equal one, maybe one heart valve, maybe more valves are involved. And the causative is mostly bacteria. Fungi may cause infective endocarditis, but more commonly you will find different bacteria that causes that. Here you may find candida as an example of fungi, and the others are bacteria. They are subdivided into acute and subacute. So you have to know that acute means that it occurs rapidly, and so the causative organism must be highly virulent. And our example here, and the classical example, is Staph aureus, very virulent organism causing acute infective endocarditis with large destructive vegetation. There is a large destructive vegetation, rapid onset for this, for the acute. And for the subacute, the less virulent organism here are examples. The classical example is a very dense streptococci. So you have to memorize well that the Staph aureus